I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. In this episode of the NEI podcast, I have here with me Dr. Andrew Cutler, and we are taking a look back at this year in psychopharmacology. Welcome, Dr. Cutler.
Well, hello, Sabrina. It's a pleasure to be here. And as Chief Medical Officer of NEI, I'm thrilled to be bringing some of the exciting new developments to our audience.
Yes. I look forward to this episode every year. It's so much fun to be able to take a look back and see just how far we've come. And we have come a long way this year. With that being said, my first question is, what are some of the new FDA approvals for medications that occurred this past year? What can you share with us?
Well, it's been a busy year, I can tell you that. So let's just dive in here. First is FDA clearance, which is what it gives to devices and software as opposed to what we call FDA approval for a medication. So the FDA gave clearance for a neuromodulation system to treat severe depression. Now, we already have, of course, transcranial magnetic stimulation and a few other neuromodulation systems, but the FDA approved a kind of modification of transcranial magnetic stimulation. This is called the SAINT neuromodulation system, developed by Magnus Medical. And this is for patients who did not improve from prior antidepressant medications in the current episode. And this was actually granted a breakthrough device designation in October of 2021. The results of a randomized clinical trial, and this was developed at Stanford, were published in the American Journal of Psychiatry and actually caused a little bit of stir in our field. And it showed that 79% of those who got the active treatment had remission from the depressive symptoms compared to only 13% in the sham arm. Now, the way this thing works is it uses structural and functional MRI to inform a proprietary algorithm that identifies the optimal anatomic target for each individual patient with depression, because we know that the neural signature can be different. So according to the company, this approach is delivered in an accelerated timeline. So you actually deliver this in a shorter period of time with more frequent sessions compared to the traditional protocol for TMS. And again, it's precisely tailored to the person's brain connectivity. We're learning more and more that depression is associated with disruptions in brain connectivity, or how different parts of the brain talk to each other, the different circuitry involved. And there's clearly a decrease, particularly from the prefrontal cortex to lower regions in the limbic area. Those parts of the brain aren't talking very well to each other.
Right.
So that's very exciting. Also, now, as far as medication, we have a very exciting approval for a new medication to treat MDD. This is not for TRD, or treatment-resistant depression, but MDD, although it can be used for TRD. And this is considered an oral NMDA receptor antagonist, which is kind of oral ketamine-like, although it actually does a lot more than that. This is a combination of dextromethorphan and bupropion, which is called Auvelity. It has a brand name. The company is Axsome Therapeutics. And this is the first and only rapid-acting oral medicine. In other words, the company has approval from the FDA to claim early onset of activity because their clinical trials separated from placebo after only 1 week of treatment. Now, they didn't study it sooner than a week, so we don't know if it would have worked within a couple of days, for instance, as we've seen ketamine and intranasal S-ketamine work within 24 hours. But still, 1 week is a lot faster than many of our traditional antidepressants. Now, what's happening here is people hear dextromethorphan and they think, oh, cough syrup. Well, yes and no. When you take dextromethorphan, you actually aren't getting dextromethorphan because it is immediately converted by cytochrome P452D6 to an active metabolite called dextrorphan, not dextromethorphan, but dextrorphan. Now, dextrorphan is a very potent NMDA antagonist, potent enough that it probably causes dissociation, so you get a PCP or ketamine-like high, and that's why people abuse cough syrup. Now, if you block CYP2D6, and you can do that with bupropion. There's also a combination of dextromethorphan and quinidine that's approved for pseudobulbar affect. And that uses that approach to block 2D6. But if you use bupropion, now you get dextromethorphan hanging around for a while. And why is that important? Well, the mechanism of action of dextromethorphan has 3 potential antidepressant mechanisms. Dextromethorphan by itself is a pretty potent serotonin reuptake inhibitor. It's also, as we mentioned, a modest NMDA antagonist. And the point here is that if you block NMDA receptors enough, moderately, you can get an antidepressant effect. If you overdo it, like with ketamine or the active metabolite dextrorphan, you get dissociation. So the dissociation is, think of it as a form of toxicity rather than therapeutics. And the third mechanism is sigma-1 agonism. This is an antidepressant mechanism by itself and also very potent anti-inflammatory mechanism. So really interesting mechanism of action that's different. Also adding the bupropion not only pharmacokinetically helps by blocking CYP2D6, but pharmacodynamically, it's a complementary antidepressant mechanism because it's norepinephrine dopamine reuptake inhibition. So very interesting pharmacokinetic and pharmacodynamic manipulation. They did 2 different studies that are in the package insert that were the trials that led to the approval. One was called the Gemini. This was a phase 3 placebo-controlled study. The other was a phase 2 Ascend study in which the combination was shown to be superior to bupropion alone. So clearly the dextromethorphan is adding something. And as I mentioned, they showed significant efficacy as early as week 1. So this is really exciting. Well tolerated. There were some side effects as you would expect, including dizziness, headache, diarrhea, somnolence, dry mouth, 6% sexual dysfunction, which is pretty good compared to an SSRI or SNRI, and a little bit of hyperhidrosis, which can be seen with bupropion. So that's really exciting. Now, as far as something else that is in the pipeline here, AbbVie has submitted Vraylar, which is, of course, cariprazine, for the approval of an adjunctive treatment for MDD with inadequate response, kind of like some of the other atypicals are FDA approved for adjunct for MDD. And very soon, coming up in December, they have what's called a PDUFA date when the FDA will rule on whether that's approved. So very soon we might have another medicine approved as an adjunctive therapy for MDD. That's very exciting. Mm-hmm. Now, as far as a diagnostic test, of course, we're all very interested in diagnosing Alzheimer's disease, and the FDA has now authorized a new test to try to improve the diagnosis. And this is a test for the early detection of amyloid plaques. And so instead of doing a PET scan or a neuroimaging, this test is called the Lumipulse test, and it measures the ratio of beta amyloid 1-42 to beta amyloid 1-40 concentrations in CSF. So I just want to repeat this. It's very important. This measures the ratio of beta amyloid 142 and beta amyloid 140. And this, of course, with other clinical information, can help determine if this is Alzheimer's or not. So a positive test is consistent with the presence of amyloid plaques, similar to what you would see in a PET scan. And the risks are, of course, getting a lumbar puncture, but also there's the risk of false positive or false negative results. Mm-hmm. So this, of course, has to be taken into account. And, of course, it's part of the clinical diagnosis that you do. But that's certainly interesting and exciting.
Yes.
Another approval that I'm really excited about is a medication for adults with ADHD, and this is a non-stimulant. So we have Viloxazine extended-release capsules. The brand name is Qelbree, made by Supernus Pharmaceuticals. Now, this medication in April of last year was approved to treat children and adolescents up to age 17 with ADHD, but April of this year, 2022, it got approval for adults ages 18 and older. And I've been very involved with the development of this medication for almost 10 years now. And so I'm really thrilled that it's gotten now approval for all ages for ADHD. The dose range is 200 to 600 milligrams. They used a flexibly dosed study. And so, again, terrific to have more options. This is only the second non-stimulant FDA approved for adults with ADHD, the other one, of course, being atomoxetine. So it's great to have more non-stimulant options, obviously.
Mm-hmm.
Okay, another interesting approval is a medication for agitation associated with either schizophrenia or bipolar disorder. And this is an orally dissolving sublingual film that contains a medicine called dexmedetomidine. So sublingual dexmedetomidine, and yes, I did practice that word. It's kind of hard to say. I had to practice it and learn it. The brand name is IGALMI, IGALMI, from BioXcel Therapeutics. And this was studied in patients with schizophrenia and bipolar 1 or bipolar 2 disorder. And the way dexmedetomidine works is it's a selective alpha 2A agonist. So it is stimulating alpha 2A receptors, and this seems to tone down the sympathetic nervous system and the release of norepinephrine, thus calming the patient. And the results did not correlate with sedation. In other words, you're not just sedating the patient and knocking them out.
Mm-hmm.
Now, intravenous dexmedetomidine has been available for many years as an aid in anesthesia. So the medicine has been around a while as an IV. But now we've got this formulation specifically. So it's really exciting. There were 2 pivotal trials, Serenity 1 for schizophrenia, Serenity 2 for bipolar 1 or 2 disorder. And the doses that were shown to be effective were 120 micrograms and 180 micrograms. It is self-administered by the patient under the supervision of a healthcare provider, and you also can give repeat doses within a 24-hour period if needed. So it's very exciting to have this option, because otherwise what we tend to do is use injections. We use shots. Mm-hmm. And the goal here is to identify the agitation a little earlier maybe and give the patient a choice to help manage their own agitation. So we're very excited to have another option here for that. Now, I just want to mention as a sidelight, this medication is also being studied for agitation associated with Alzheimer's dementia, which is a significant problem and often leads to patients with Alzheimer's being hospitalized or institutionalized, let's say in a nursing home. And so that would be exciting. And there's actually 2 other medications being developed for that exact indication. One of them is brexpiprazole. The brand name is Rexulti, an atypical antipsychotic that's already on the market. But they have 2 positive studies that they have submitted to the FDA for agitation associated with Alzheimer's dementia. And all preliminary indications are looking good that this medication could get approved soon. The other one is the drug I mentioned previously, the combination of dextromethorphan and bupropion. Brand name is Auvelity by Axsome, which is being studied also for this indication, based on the fact that dextromethorphan has been shown to decrease impulsive emotional outbursts. Remember, I said that combined with quinidine, it's approved for pseudobulbar affect. That drug is called Nudexta. So we've known that dextromethorphan may help with what pseudobulbar affect is really dysregulated emotional outbursts, and that can include agitation. So that's very exciting. Okay, back to the ones that were actually approved this year. We have a new drug approved for insomnia, and this drug is called daridorexant. The brand name is a little funny. It's Quviviq, Quviviq, Quviviq. Not Quviviq, but Quviviq, and the company that makes it is called Idorsia. 25 and 50 milligram pills to treat adults with insomnia. Now, daridorexant is a DORA. It's a dual orexin receptor antagonist, and there are 2 others already on the market. This one, though, appears to have very favorable pharmacokinetics, a favorable pharmacokinetic profile with a shorter half-life, so perhaps less risk of next-day sedation. And the other thing that they did was they actually did studies looking at next-day functioning and showed improvements in next-day functioning, which hadn't been shown with the others. And so they have a little bit of a unique claim that they can talk about not only improving insomnia, but also improving functioning. Mm-hmm. Now, the way that these drugs work is if you block orexin receptors. Orexin is a wakefulness promoting neurotransmitter in the brain. And so if you block that, you sort of shut off the wake signals and allow someone to fall asleep. So very, very exciting to have another option here. And I mentioned the favorable PK. The half-life is only about 6 hours as opposed to the others that have much longer half-lives.
Oh, wow. Yeah, that's great.
Yeah. So those are some of the approvals and I guess some of the pending approvals.
Yeah. Wow. So much has happened. What did we learn about the association between ADHD and cardiovascular disease from research findings this past year?
Well, this is a very important association because we know that adults with ADHD are in general heavier than adults without ADHD. There's more obesity.
Oh, wow.
And yes, we know that there's more cardiovascular disease and more diabetes. So this is fascinating. There's all kinds of theories as to why that might be. And a study was done this year or published this year that was done, a lot of the studies we're going to talk about are either from Sweden or Finland because they have tremendous databases. They keep real detailed health information on their populations. And this one was a cohort study from Sweden. And it looked at the association as well as possible co-founders, such as taking psychotropic medications, some of which can cause weight gain or cardiovascular risks. So adults with and without ADHD with no pre-existing cardiovascular disease at baseline, and this was over 5 million patients, were followed for an average of almost 12 years. This is incredible.
Yeah, it is.
And a total of about 0.7% of this database was diagnosed with ADHD or had an ADHD medication prescription. Now, what that tells me, because we know that the incidence is much higher than that, that tells me that there's a lot of people who are not diagnosed, most likely. But anyway, those who were diagnosed with ADHD, there was a significant association with increased risk of cardiovascular disease. The hazard ratio was over 2, meaning there's over a doubling of risk of cardiovascular disease. And even when they adjusted for confounders that included diabetes, obesity, dyslipidemia, smoking, etc., the strongest associations were for cardiac arrest or heart attack, for hemorrhagic stroke, and peripheral vascular disease or atherosclerosis. And men and younger people, ages 18 to 30, had the strongest association compared to women and older people. However, the risk was still increased no matter who you were. So this suggests that ADHD is a risk factor for cardiovascular disease regardless of psychotropic medications and family history of cardiovascular disease. So ADHD is an independent risk factor for cardiovascular disease. As I mentioned, it increases the risk more than twofold, more than doubles the risk. So probably we should be screening our ADHD patients for, cardiovascular disease, but also diabetes, metabolic disturbance. And we know that people with ADHD tend to smoke more. We know they tend to overeat more because overeating is a form of self-medication. It increases dopamine. We know ADHD is dopamine dysregulation, so it's hard for people to moderate their behavior, especially when talking about pleasurable behaviors. So I think this is a very important finding that we need to take into account.
So what other research findings were discovered this past year when it comes to ADHD? What else can you share with us?
Well, ADHD is always a very hot topic for our NEI members and attendees. And I want to mention one particular study that looked at the use of complementary and alternative medications. So nutritional supplements, for instance, herbal treatments, things like this. And many of these are not evidence-based, but there are some that do have some evidence. For instance, exercise has powerful evidence that it helps ADHD. Omega-3 fatty acid supplementation, especially higher doses, over 2 grams a day, and meditation and mindfulness kinds of interventions. Well, in this study, patients with ADHD included 4,447 patients from different studies, and the use varied from 7.5% to over 2/3, 67.6% of patients with ADHD, suggesting that probably a lot more of our patients are doing this than we realize. And the study found that parents of children with ADHD with higher education were more likely to use these complementary and alternative interventions. And so this is something that could be a predictive factor, and you should maybe ask a few more questions or screen a little more carefully.
So interesting.
Let me tell you about another one, and this one might be very surprising, but I think helpful for our audience. And this builds on some research in the bipolar disorder field. But let me just tell you what this one shows. This particular study showed that children and adolescents with ADHD were associated with an increased risk of migraine headache.
Wow.
Isn't that remarkable? Now, our friend Roger McIntyre a few years ago published that patients with depression and migraine headache were 2.5 times more likely to be bipolar. So there's an association not only of bipolar disorder, but also ADHD with migraine. I just find that fascinating because there is a probably genetic and neuropathologic overlap between bipolar disorder and ADHD. So this is really fascinating. This came out of Taiwan study looking at the Taiwan National Health Insurance Database.
Wow.
So very important.
Yeah, absolutely. In a pilot study that was conducted earlier this year, what did the findings suggest about a potential biomarker for depression and antidepressant treatment?
Well, this is really interesting, and this one also caused a lot of stir in the field. This was a pilot study, so we have to interpret this with a little bit of caution. This was a study looking at a peripheral biomarker, which is something that can be measured in the blood for depression and for antidepressant response. So what's going on here, this is taking advantage of a biologic process. We know that in depression, heterotrimeric G protein, GS-alpha, so this is called GSA or GS-alpha, is sequestered in what's called lipid rafts, which is a strange way of describing, because architecturally, when you visualize these things, they look like rafts. And this leads to a reduction in the activity of adenyl cyclase. Antidepressant treatment, successful antidepressant treatment, translocates the GSA from these rafts and facilitates the stimulation of adenyl cyclase in the non-RAF membrane fraction, and you measure this by prostaglandin E1 stimulated adenyl cyclase activity. My God, this is a mouthful, right?
Yes.
So in this study, they looked at PGE1 activation of adenyl cyclase, and what they found was an association between patients with MDD and a lower PGE1 activation of adenyl cyclase than controls. And this was determined by looking at platelets. After 6 weeks of open-label antidepressant treatment with a variety of SSRIs or SNRIs, MDD patients who were responders had a significant increase in this PGE1-stimulated adenyl cyclase activity, a 62% increase, compared to non-responders who only increased this activity by 4.6%. So the PGE1 stimulation increase by at least 30% from assessment had a positive predictive value for responding to an antidepressant of 80%. Now, this is really potentially exciting.
Yes.
So potentially we have a blood test that can help diagnose MDD, but also help monitor treatment response. So this is exciting. Of course, we need more data on this. But, the holy grail for psychiatry has been biomarkers that can help us to better identify populations and especially to identify those that may respond to our treatments.
Wow, those are such interesting findings and pretty exciting. What else can you share with us in terms of other research findings? What else did we learn about mood disorders this past year?
Well, we've known about an association between inflammation and depression, but a study here looked specifically at the association with symptoms of anhedonia and low functional connectivity. We talked a little bit about functional connectivity earlier when we talked about the SAINT protocol. And so it has been reported that increased plasma C-reactive protein or CRP concentrations with inflammatory cytokines have been associated with low resting state functional connectivity, especially between the prefrontal cortex and the ventral striatum, which is where the nucleus accumbens and the limbic systems live. Well, in a recent study, adult outpatients with MDD were looked at 2 visits. They were given the dopamine precursor, L-DOPA, 250 milligrams versus placebo, and these were 1 week apart. Inflammation was measured using C-reactive protein. The primary outcome was looking at their resting state functional connectivity between the ventromedial prefrontal cortex and the ventral striatum. This is considered the reward circuit. And a CRP value of greater than 2 milligrams per liter was considered the cut point for those that had inflammation and that had positive functional connectivity responses to L-DOPA. So in other words, those that had more evidence of inflammation seemed to do better with the L-DOPA. And so, and also effort-based motivation outside the scanner, which is correlated with anhedonia, positively correlated with functional connectivity independent of treatment or CRP, and change in anhedonia scores negatively correlated with functional connectivity after L-DOPA only in those with the CRP elevated to greater than 2, thus evidence of inflammation. So pulling back and saying, what does this mean? Inflammation is associated especially with anhedonia and with disruptions of the functional connectivity of the prefrontal cortex to reward circuits in the nucleus accumbens and limbic system. And this suggests that treatments that may improve dopamine, dopaminergic treatments, might be especially helpful for depressed patients with inflammation and anhedonia. And we've known anhedonia, of course, is motivation, reward, pleasure, and that involves more dopamine than any of the other neurotransmitters. So that's very exciting. Now, I want to talk about one other interesting interventional treatment, and this is looking at ketamine. And we know that ketamine works for depression, for anxiety, for PTSD, and other things. But of course, going to a ketamine clinic, and as a matter of fact, my wife just yesterday asked me if I knew of a ketamine clinic in our area because a friend of hers has treatment-resistant depression and wants to try ketamine. And, we had a little trouble finding them, and they're expensive. So guess what? Ketamine is now being investigated as a at-home treatment option. Well, if you go to the internet, you'll see a number of websites that are offering at-home ketamine treatment. So how can this be? Well, a sublingual ketamine treatment has been developed that can be used at home, and it's paired with a telehealth appointment at the start of the session. And in a recent study, over 1,200 patients between 19 and 76 years old completed 2 medication sessions. Participants were given 300 to 450 milligram doses of sublingual rapidly dissolving ketamine. And it's interesting, they gave ondansetron concurrently for nausea, which is a common side effect of ketamine. And the way it worked was they had a short 30-minute meeting with their guide before taking the medicine. Then they lie down for an hour and journal for 30 minutes. So they take the medicine, lie down, and then journal for 30 minutes. Statistical analysis found 3 subgroups. 79.3% of these patients improved with the first treatment. 11.4% did not respond. And there was a group, 9.3%, that responded only after the second treatment. So they were called the delayed improvement group. This is really remarkable that such a big percentage of patients responded. As a matter of fact, only 6 patients dropped out of the study, so it was very well tolerated. And when subanalyzed, 63% of depressed patients and about 63% of anxious patients showed clinically significant improvements with effect sizes that were whopping 1.6 and 1.56.
Wow.
I mean, these are huge effect sizes.
Yeah.
And we have come to expect ketamine to be effective. And, it's interesting that ketamine, now we're learning, does not have to be given intravenously, but it just needs to be given parenterally, which can include intramuscular, sublingual, intranasal. So this is really an exciting development. Of course, we have to make sure that the supervision and the monitoring that's given through these outlets is appropriate. For instance, blood pressure ideally should be monitored. Ketamine can increase blood pressure.
Yeah. What were some other research findings with respect to mood disorders this year?
This is controversial because it involves pharmacogenomic testing. And we know that there are some people who are very pro pharmacogenomic testing, and some are anti, and some are in the middle. A recent study of almost 2,000 patients were looked at, and they had two groups. One group was clinicians given the results of the pharmacogenomic test right away and then initiating treatment. And then a group that was given usual care, and they only got the results of the PG testing after 24 weeks, so delayed. And what they found was that among patients with MDD, the clinicians who got the pharmacogenomic testing had reduced use of medications with drug-gene interactions, and the pharmacogenomic guided group was more likely to get a medicine with a lower potential for drug-gene interaction or no drug-gene interaction as opposed to the other group. Also, remission rates over 24 weeks were higher amongst patients whose care was guided by the pharmacogenomic testing with an odds ratio of 1.28. In other words, they were 28% more likely to respond.
Right.
Another wrinkle of major depression is we know there's a very high rate of comorbidity with alcohol use disorders, and we know that such patients tend to have worse illness and they're harder to treat with worse prognosis. And when you try treating these folks with, our usual antidepressants like SSRIs, SNRIs, and even tricyclics, doesn't always produce the best results. So a study was done using a newer antidepressant, vortioxetine. And this was a study of 57 patients with depression and comorbid alcohol use disorder and 56 patients with MDD without alcohol use disorder. And the doses used were 10 to 20 milligrams a day of vortioxetine for 6 months. And what they found was there were improvements in both groups in terms of their depression scores measured by the MADRS, and also on various other ratings, including anhedonia using the SHAPS, anxiety using the HAM-A, cognition using the digit symbol substitution test, and the Perceived Deficits Questionnaire for Depression. Also, functioning scores using the FAST, the Functioning Assessment Short Test, and finally, quality of life using the QLI, the Quality of Life Index. Interestingly, the presence of MDD doubles the risk of having alcohol use disorder and vice versa. There's a bidirectional relationship. And so it's possible that prolonged exposure to alcohol may lead to neurophysiological and metabolic changes that spark depression, and the presence of depression may spark alcohol use for patients trying to self-medicate, feel better. Alcohol, as we know, can increase dopamine. Alcohol stimulates the GABA A receptors. And so what's really exciting here is that a combination of vortioxetine plus a treatment for alcohol use disorder may really have good outcomes, better than standard antidepressants. Another very important study that I want to quickly mention, we think about sometimes what's the best thing to do? Treat somebody with depression with a monotherapy antidepressant? Should we switch? Should we combine? And a recent study that was really interesting that I know our friend Dr. Stephen Stahl was particularly interested in was a large meta-analysis looking at randomized clinical trials looking at combinations of antidepressants versus antidepressant monotherapy. They included 39 clinical trials that were done from 1977 to 2020. And what they found was combination treatment was significantly better at improving treatment outcomes relative to monotherapy with an effect size of 0.3, a good modest effect size here. And particularly, specifically, when they looked at combinations including presynaptic alpha-2 autoreceptor antagonists, and the most commonly used one is mirtazapine, they found that that was especially superior, and it could be the combination of presynaptic alpha-2 antagonism, which disinhibits the release of serotonin and norepinephrine, combined with monoamine oxidase inhibitors or reuptake inhibitors, gives you a synergistic increase in serotonin and norepinephrine release. And there's one particular combination that Dr. Stahl has popularized. It's a combination of mirtazapine and SNRIs, and he calls this California rocket fuel. And the combination is thought to be very powerful and to maybe blast people out of depression. So it's a very interesting finding, and it may be a safe alternative compared to things like augmenting with an atypical antipsychotic or lithium. Now, speaking of that, another study looked at best ways to treat a treatment-resistant depression and investigated a couple of adjunctive treatments. In this case, they specifically looked at adjunct with second-generation antipsychotics, S-ketamine, and lithium. The most effective was actually lithium with an NNT of 5. S-ketamine was next with an NNT of 7. And second-generation antipsychotics had an NNT of 11. So all looked effective. Tolerability was also best with lithium with a number needed to harm, or NNH, of 9. S-ketamine had an NNH of 5. And SGAs also an NNH of 5. So this suggests that all three are very reasonable, but that lithium had the best kind of balance of efficacy and tolerability. And so lithium is an underused augmentation agent, as are alpha-2 antagonists like mirtazapine. So this gives clinicians maybe some other options to consider for their patients with treatment-resistant depression.
Wow. That's so exciting. Is there evidence that pherines can reduce anxiety? What can you tell us about the research that came out this year? Can you start by telling us what pherines are?
Pherines are synthetic neuroactive steroids that are delivered intranasally. And what they do is they engage nasal chemosensory receptors without inducing a sense of smell. So you don't smell these, but they are activating neurons in your nose, these chemosensory receptors, and these are directly wired to the limbic amygdala. And if you use these pherines, they actually don't cross the blood-brain barrier. They don't enter the systemic system. They are just stimulating these neurons that then directly connect and stimulate the parts of the amygdala. And they have rapid and potent effects on the autonomic nervous system. They can decrease sympathetic tone and cardiac and respiratory rate. And this is similar to some circuits that have been involved in the pathophysiology of various anxiety disorders and depression. There is a particular pherine called PH94B. There's a company called Vistagen that's investigating this. And this is shown to be more effective than placebo in reducing performance and social anxiety in patients with social anxiety disorder. It's also shown to significantly decrease peak anxiety during social and performance events in the daily lives of patients with SAD. And the anxiolytic effects have been seen very early, within just a few minutes, and are comparable to the effects seen after 12 weeks of FDA-approved medications with much better tolerability, virtually no significant side effects. Now, they also have developed another neuroactive steroid pherine called PH10 that they're studying for depression. And this has been shown in a pilot study to potentially work within the first week of treatment. So this is certainly very exciting, very favorable safety profile. Again, they don't enter the systemic system, they don't get into the blood, and they don't cross the blood-brain barrier. So this is really exciting.
What were the research findings from a cohort study that examined the relationship between the gut microbiome and mental health in patients with PTSD?
The microbiome gut-brain axis, we know, has been associated with depression. Roger McIntyre's published on this, both unipolar and bipolar depression, but there's also an association now being seen for PTSD. And in a recent cohort study, this was looked at, and they did stool samples on a bunch of patients. And what they found, actually 79 patients with PTSD and 58 controls, they found 4 specific genera of microbiome or bacteria. I'm going to butcher this, Mitsuokella, Otorobacter, Cantinobacterium, and Olsonella were seen as distinguishing patients with PTSD with over 2/3, 66% accuracy. Also, the relative abundance was higher in patients with PTSD and correlated positively with the CAPS-5, which is the standard PTSD rating scale. MDD diagnosis was also associated with a relative abundance, particularly of the Bacteroides phylum, and Roger has published on that exact same thing as well. So this is really exciting and information that may ultimately lead to some treatment interventions manipulating the microbiome, the gut, maybe with probiotics or prebiotics.
What was reported about paternal comorbid depression and anxiety during the first and second year postpartum?
Well, in a recent study that is fascinating to me as a father, and that is looking at the prevalence of paternal depression and anxiety in the postpartum period and in the first and second year postpartum. And what's been really, this has been very understudied. We know a lot about maternal postpartum depression, but it turns out there is an increased risk of depression and anxiety in the fathers in the postpartum period and the period of 1 to 2 years following. So what was found in this particular study was 22.4% of 569 fathers had comorbid depression or anxiety at some point in the first year postpartum and 13.2% in the second year postpartum. So this is really quite impressive. And some of the risk factors they found was a family income supporting more than 4 people, so increased financial stress. And also other factors included poor or fair perceived health at 4 weeks postpartum, paternal depression prior to pregnancy, so a pre-existing history of depression, also a paternal anxiety during the pregnancy, paternal ADHD, believe it or not, maybe feeling overwhelmed and disorganized with having to manage this, various indicators of social support, the quality of the partner relationship, exposure to partner violence, and parental satisfaction. So this is something that's also very important.
What did a study on 2 independent cohorts in Sweden and Finland discover about the relationship between effective treatment for schizophrenia and substance use disorder?
Research on the relationship between treatment for schizophrenia and prevention of substance use disorder is lacking. We have some data on treating comorbid or dual diagnosed schizophrenia with substance use disorder. But in a study, again, using large population databases from Finland and Sweden, was looked at to see if certain antipsychotic interventions could prevent comorbid substance use disorder from developing. So there was one cohort of patients from Finland. Over 45,000 patients were followed for up to 22 years from the Finnish database and up to 11 years in the Swedish database. The findings were very interesting. For patients with schizophrenia who did not have substance use disorder initially, clozapine was associated with the lowest risk of developing substance use disorder in both countries, with a decreased risk of 70 to 80%. Also, antipsychotic polytherapy was also associated with a lower risk of about 50%. And the risk of relapse, including psychiatric hospital admission or substance use disorder-related hospital admission, was lowest for clozapine, antipsychotic polytherapy, and, of course, long-acting injectables. So this really says that we need to especially be thinking about clozapine, and I would argue LAIs, and maybe having to use more than one antipsychotic in certain situations.
What else did we learn about psychosis this year? What can you share with us?
We have some very clear evidence that marijuana use in pre-adulthood, in adolescence, is very bad for the brain and does increase the risk of psychosis. Well, a new study suggests that cannabis use is associated with poorer mental health outcomes. This was a large meta-analysis of 20 studies with over 580 participants. And what they found was an association between the potency of marijuana use and the frequency of the use and psychotic symptoms, anxiety, depression, and of course, cannabis use disorder. So this is obviously something that we need to take into account because the data on the use of cannabinoids for treating mental disorders is very weak at this point. So at this point, the potential benefit does not appear to be very good, and the potential harm is clearly established. Another study I want to review real quickly here, which was published by our good friend Les Citrome, has to do with looking at hostility symptoms in patients with schizophrenia, and this came from a pivotal trial done with an acenapine transdermal patch called Sequado. And in the pivotal trial, Les subanalyzed hostility symptoms, and he found a very significant improvement in hostility in 2 different doses of the sublingual acenapine versus placebo. So this is certainly an option to consider as opposed to, as we mentioned, the sublingual dexmedetomidine and injectable antipsychotics.
What were some of the novel findings on addiction?
we really need treatments for addiction and substance use disorders. And one particular study that is very exciting had to do with psilocybin for alcohol use disorder. Psilocybin is, of course, sometimes called mushrooms or magic mushrooms. In this particular study, 95 participants who had alcohol dependence were randomized to psilocybin, either 25 milligrams per 70 kilograms or 25 to 40 milligrams per 70 kilograms, or a dose of diphenhydramine that was considered placebo to give at least some kind of psychoactive effects, 50 milligrams and 50 to 100 milligrams. And these were done in 2 different sessions that included psychotherapy, motivational enhancement therapy, and cognitive behavioral therapy. They were monitored for a couple of outcomes: heavy drinking days, total number of drinking days, and the number of drinks per drinking episode over a 32-week period. What they found was very interesting, very significant efficacy on a number of these measures. So specifically, reduction in the number of heavy drinking days, the number of drinking days in general, and the number of drinks consumed in an episode. And especially those treated with psilocybin were more likely to have no heavy drinking days, and a 2-level reduction in the WHO risk level during this observation period. So this is really quite exciting preliminary evidence that psilocybin may be an effective treatment for alcohol and possibly other substance use disorders. I want to talk about a study that looked at risk in especially adolescent alcohol use. And this was an interesting study looking at solitary alcohol use versus non-solitary alcohol use in adolescents and young adults. And what they found was a clear association between both adolescent and young solitary alcohol use and subsequent problems in adulthood, such as binge drinking and alcohol use disorders. So this is something that we need to take into account now when we're screening our adolescent population. Not only do you drink and how much do you drink, but do you drink alone? This is a question we don't always ask, and that has clearly been shown to be an independent risk factor now for more problems later on in life. We have not very great treatments for tobacco use disorder. Unfortunately, smoking cessation rates when people try to quit on their own are only 3 to 5%. And while the outcomes double to 7%, that's still pretty low if you use CBT, nicotine replacement therapy, varenicline, or bupropion. We know that about 15% of the general population smokes daily, and we know it's higher in patients with ADHD, depression, schizophrenia, and other severe mental disorders. So this is a very important problem here. Well, a recent study was done looking at non-invasive brain stimulation, and there were 2 different modalities studied, transcranial magnetic stimulation and transcranial direct current stimulation. And what you do is you target the prefrontal cortex because of its role in salience, attribution, and self-regulation. Patients who underwent these treatments were 139% more likely to be abstinent at 3 to 6 months following smoking cessation compared to placebo. These are preliminary findings, but boy, is that exciting.
What did we learn about Alzheimer's disease and dementia this year?
What one recent study has shown is that if you look at 356 cognitively unimpaired older adults, so ages 60 and over, with a mini mental status exam of 28 to 30 showing no significant cognitive impairment, and they followed these people for 8 years, and they looked at apathy, anxiety, and depression, as well as cognition. They also measured levels of cerebrospinal fluid amyloid beta 42, amyloid beta 40, and neurofilament tangles, neurofilaments. And they did an MRI also looking for white matter lesions. And what they found was that there was clear increases in apathy and in anxiety and depression correlated with lower levels of CSF amyloid beta 42 to 40 ratio, indicating more plaque deposition in the brain, and higher or more abnormal CSF levels of neurofilaments. Higher white matter lesion volumes were also associated with apathy. There was no association between baseline pathology and depression scores. So the worsening of apathy also was found to be largely independent of the cognition, indicating that change in cognition does not fully mediate this worsening of apathy. What this shows is that the Alzheimer's disease pathology, and especially the amyloid beta pathology, may have a detrimental effect on the worsening of neuropsychiatric symptoms, especially apathy. And so neuropsychiatric symptoms may predict future cognitive decline, and that apathy may be due to pathology in the frontoparietal control network. These are very important findings and may influence further treatment. I know, for instance, there are some treatments being developed for apathy specifically that may be used in the Alzheimer's population. Okay, we know that there has been associations between benzodiazepine use and dementia, but a recent national cohort study looked at the association between opioid use and the risk of dementia. Now, this was a sample of Israeli citizens aged 60 and over, and these were patients without a history of dementia or not having taken a dementia medication in the previous 10 years before the study. This was over 91,000 people studied. During the follow-up, about 3% of the people were opioid exposed at a mean age of 74, and 5.8% of all the subjects developed dementia at an average age of 78. What was really interesting here was that after accounting for age, sex, and comorbid health conditions, they found an increased risk of dementia in those who were opioid exposed versus those who were not, with a 1.39-fold greater risk of developing dementia. This is quite remarkable. The dementia rate was consistently larger for each age group they studied for opioid exposed versus unexposed, and this suggests that opioid exposure can be a clinically relevant modifiable dementia risk factor. So we need to be very careful with our use of psychotropic medications, especially opioids and benzodiazepines in older folks.
This is all such great information, Dr. Cutler. Do you have any final news about psychopharmacology that you want to share with us this year?
Okay, well, let me tell you about a couple of other really quick relevant developments in psychopharmacology. We have 3 findings. In July of 2022, the FDA released a resource for consumers to provide education for dietary supplements, and they recommend especially talking with your doctor, pharmacist, or other healthcare professional before using a dietary supplement, because these things can contain all kinds of interesting ingredients and they're not rigorously studied. Now, another study published in March of 2022 suggests that youth concussion, especially between the ages of 5 and 18, is associated with an increased risk of mental health issues, psychiatric hospitalizations, and self-harm. So this is very important to consider when you're thinking about youth sports and protecting youth from concussions. And finally, a study published in April of this year reported that MDMA-assisted therapy significantly reduced eating disorders. Now, this is fascinating. We've talked about various psychedelic medications for depression, for PTSD, but now we're talking about this for eating disorders. So stay tuned. There's a lot of psychedelics in development for a variety of psychiatric disorders. Now, for ongoing updates of what's happening in the field of psychopharmacology, NEI members can access our feature called This Month in Psychopharmacology. And please check out our website at www.neiglobal.com for more information. Thank you.
Thank you so much, Andy, for being on our show, and thank you all for listening. Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.